of exon 50, which then causes an out-of-frame mutation, and then an absence of dystrophin, and then the manifestations of Duchenne's muscular dystrophy. Here you have dystrophin, which is causing an exon 51 skip, which then restores the reading frame, produces dystrophin, smaller, novel, with the hope that that is functional, similar to the phenotype of Becker's muscular dystrophy. Now moving on to the earlier studies that were completed by Regents, and this was an early study in 12 boys with Duchenne's muscular dystrophy, and they collected muscle biopsies looking to see if the amount of dystrophin had increased, and you can see that with the immunofluorescent pictures on the right hand side, or on the bottom, there was an increase in the green intensity versus the picture above it. That then gave proof of mechanism, and then subsequently the proof of concept. GSK then in-licensed the compound in 2009, where we then conducted 2 phase 2 studies and a large phase 3 as well. And I'll take you through our program here. So just working through the list, starting at the top, that was the 12-boy study that I initially spoke about, which was a Regents study, which has then since become a GSK study. And those boys now have been dosed for around about 4 years. And out of those 12 boys, 8 of those are quite close to their baseline and are still walking. Next one down is the 117. This was a phase 2 double-blind, placebo-controlled study in 54 subjects. And the primary endpoint was the 6-minute walk distance. And at 24 weeks, there was a statistically significant difference of 35 meters versus placebo. And that was then followed through at 48 weeks. Although not statistically significant, it was still clinically meaningful around the 35 meters mark. The next study is the phase 3 study, and I'll spend a bit more time on that. So just moving to the last one at the bottom is the 876 study. That was a US-specific study, a phase 2, once again, double-blind, placebo-controlled study in 54 subjects, where we looked at 2 doses, 6 milligrams per kilogram, and then a lower 3 milligrams per kilogram. And at 24 weeks, what we found was that the 6 milligrams per kilogram, there was a clinically meaningful difference of 27 meters between that dose and the placebo, but there was no difference with the 3 milligrams per kilogram dose. So now I'm going to spend some time on the phase 3 results. So here was the study design. It was a randomized, double-blind, placebo-controlled study. And for every 1 patient on placebo, there were 2 on dystrophin. And we aimed for 60 patients with placebo and 120 with dystrophin. And we actually did better than that in terms of recruitment, where with the active arm, we had 125 patients and 61 on placebo. Boys were initially screened and then followed up for 48 weeks, where that was then the primary endpoint, and then they had a 20-week follow-up, more from a safety perspective. Here are the study objectives and the inclusion criteria. So the primary endpoint was the 6-minute walk distance. So just to remind ourselves, that's the distance a boy can walk in 6 minutes. The secondary objectives, in terms of efficacy, effectiveness, were the key secondaries, and these are key secondaries which are defined in the statistical plan. And these are assessments which do have a close correlation with the 6-minute walk test, as identified in independent research. So we had the North Star, which has since been linearized, the 10-meter walk run, and the 4-stair climb velocity. Other secondaries were rise from floor, muscle strength, pulmonary function, and also CK, creatinine kinase levels. We looked at safety, tolerability, pharmacokinetics. This is how the body affects the drug in terms of absorption, distribution, metabolism, excretion, and quality of life. Quality of life is independent to the investigator assessments. Quality of life is assessed by boys in the clinical trial and their parents as well. Key points to note in terms of the inclusion criteria for the study is that boys had to be above the age of 5. They had to have a mutation which was correctable by a 51 skip, and the minimum distance they had to walk was 75 meters. What was different with this study, which was different to the other 2 phase 2 studies I mentioned, is that there was no rise from floor. In the 876 and the 117 studies, a boy had to rise from the floor within 7 seconds. And here are the baseline characteristics. And you've got to remember that for every 1 placebo boy, there was 2 on dystrophin, and they were evenly matched. and well distributed in terms of age and baseline. The 330 metre cutoff is important, as their natural history data suggests that boys who have a walking distance of greater than 330 metres are possibly more destined to be ambulant walking in 1 year versus boys who have a less than 330 metres. But both groups were well matched for that as well, and also for steroids. So here's the effectiveness graph, and I'll just take you through it. So on the vertical axis, we have the 6-minute walk distance change from baseline. So anything above the horizontal line is an improvement, and anything below it is worsening. We then have time on the bottom, 12, 24, 36, 48 weeks. The blue line is placebo, and the green line is dystrophy active treatment. So at 12 weeks, we had 44.7 metre difference. At 24 weeks, we had 4.8. At 36 weeks, we had 1.8 metres. And at 48 weeks, which was the primary endpoint, we had a 10.3 metre difference, which was not statistically significant. And in terms of clinically meaningful, independent research tells us that 30 metres is what's graded as being clinically meaningful. And here is some additional analysis that we completed. So this is a predicted 6-minute walk test. So there's an equation which factors in age and height, and then in some ways factors in maturation and development of a boy. But there was no difference between placebo and dystrophy. That was statistically significant or clinically meaningful. And here we looked at now we know that there's certain patient characteristics from natural history studies which tell us that can influence the 6-minute walk test. For example, the baseline 6-minute walk test, or age group, or rise from floor. And we looked to see, was there any differences between dystrophy and placebo for these groups of boys, and there wasn't. We also looked at age group, boys who were below the age of 7, and what we did find was that there was a 21 metre difference, which wasn't statistically significant, but close to the clinically meaningful value. And above the age of 7, there was a 6.9 difference. Now, the numbers are small, and we are looking at this more closely in terms of doing additional analyses for this. There are some more key secondary endpoints. There was the North Star, which assesses ambulant function, and since then it's been linearized to make an assessment more on progression. But there was no difference between dystrophy and placebo, and the same was for the 4-stair climb and also the 10-metre walk. There were the other secondary endpoints, and they showed a similar pattern: rise from floor, 4-stair, descent, and also muscle strength as well. One of the secondary endpoints that we did was creatinine kinase. Now, creatinine kinase is a muscle enzyme which is produced from damaged muscle. And we know that boys with Duchenne muscular dystrophy do have a high level, even at an early age. And therefore it does have diagnostic value. But in terms of the prognostic value, I think that's still debatable. But what we did find was that in this study, there was a statistically significant difference with dystrophy and placebo with the creatinine kinase level. The creatinine kinase level reduced. And this is something that we need to look at closely in terms of the additional analyses that we're doing. At the bottom, you'll see that there was no difference with pulmonary function test and also quality of life assessed by the boys and the parents as well. So now moving on to safety. So adverse events were more common in the dystrophy group versus the placebo, and I'll come to some of those in a few minutes. We did have 2 serious adverse events. One was of glomerulonephritis, which is a severe type of proteinuria, and another was intracranial venous sinus thrombosis. Both boys discontinued dystrophy and withdrew from the study, and both boys have since recovered as well. Here we have the adverse events, which are of special interest. So special interest in terms of that, as the animal data that we've done and the early clinical studies have pointed to these key areas: injection site reactions, renal in terms of proteinuria, and they were more common in the dystrophy. In terms of the hepatic, that we feel is a false positive. That was really by a liver enzyme, but on repeating, the test was actually normal for this boy. So So in conclusion, these results are obviously disappointing for us in GSK and also for the community. From an effectiveness perspective, there was no statistically significant or clinically meaningful differences that were observed with a 6 milligrams per kilogram week dose versus placebo on the 6-minute walk distance at week 48. There was not a clinically significant treatment difference on the secondary endpoints. There was a decrease in CK, and we need to look at that very closely. And the placebo group declined as expected per natural history data. From a safety perspective, the overall safety profile was consistent with that seen in the other Duchenne studies. There were these 2 adverse events, and most adverse events were really, as we previously had predicted, was injection site reactions and proteinuria. So in terms of next steps, you need to look at the data more carefully and closely. For example, the muscle biopsies, that's something that we're waiting on, and we're doing biomarker and pharmacodynamic effects and just looking at dystrophin levels as well. And we're also pooling all the data together from the phase 2 studies and the phase 3 studies and doing additional analyses, looking, for example, at the predicted 6-minute walk test, and also looking at the boys who improved on their creatinine kinase to see, is there any subgroup of boys who do have a positive benefit risk that will allow us to continue dosing with Duchenne. And we're also not just confining these analyses to year 1. We have an additional 48 boys who actually have another 48 weeks data as well for year 2, and that's something that we're also looking at as well. And just to mention that a lot of these analyses, all of these analyses, we're doing with, in collaboration with researchers and investigators and with our Presenter colleagues in order for us to make a decision with Duchenne. And finally, I'd like to thank the study teams and the investigators for their participation in the study. But personally, I'd like to thank all the boys and their families for all the contributions in the study. I know it's been difficult, particularly at this present time, but I'd like to thank you.